Hello, everybody. Welcome, welcome, welcome. We are glad that you are here with us tonight. And we have a special treat for you guys. I hope that you have been tuning in with us for these last couple of rounds that we've had for these journeys. But if not, you are in for a treat because we have some special doctors that we are going to be joining us on tonight. And so who we're going to talk to tonight are a couple different people. So let me first introduce you to Kimberly Alexander. So Kimberly is the founder of AJ's Fight. And AJ's Fight is an organization that funds medical research, community education, and offers support to people with eosinophilic esophagitis, which requires severe food restrictions. Kimberly, say hello.
Hey guys, nice to see you.
We also are joined by two of Kimberly's amazing doctors, Dr. Anthony Olive and Dr. Carla Davis. Let me first introduce you to Dr. Olive. Dr. Olive is the Associate Professor of Pediatrics at Baylor College of Medicine, the co-director of the Eosinophilic Gastrointestinal Diseases Clinic of Texas Children's Hospital, and a board member of AJ's Fight. Carla Davis is the professor of pediatrics of Baylor College of Medicine, the chief section of immunology, allergy, and retroviral, and director of food allergy program of Texas Children's Hospital, and a board member of AJ's Fight. Welcome.
Thank you.
Thank you. Nice to be here with you all.
So we'll get started. Just give you guys a moment to talk about how you got into EGID, eosinophilic gastrointestinal disorders, why you got into EGID, and to give us a few definitions of what those things are. I'll start with you, Carla.
Okay. I became interested in EGID, which is eosinophilic gastrointestinal disease, when I started as a faculty member and started the food allergy program, because at that time it was a relatively new disease. We didn't know much about it, and I felt like I could make a difference in this area. Serendipitously, Dr. Olive was interested as well, and so his interest, as well as the fact that there was so much to learn about it, and there was a lot of excitement about learning about this disease, was the reason why I got into the field.
Okay. And Dr. Olive?
Yeah, I think that's right. I think we, really sort of came about from us seeing a lot of these patients with this relatively new condition, and we started seeing more and more of them. And I remember Carla and I would run into each other in the hallway and sort of discuss mutual patients. And one day we said, well, why don't we just have a clinic together instead of discussing them out here in the hallway? And that was back in 2010. And that's kind of when things started for our eosinophilic gastrointestinal disorders clinic. And luckily we've been able to grow it some recently with the addition of Dr. Chu on the GI side and Dr. Anvari on the allergy side, and now Dr. Buhais out at West Campus, and soon to expand to the Woodlands campus as well. So it's kind of grown over the years, as has the field.
And Dr. Davis, how many patients would you say are part of the clinic?
We have about 200 to 300 patients now.
Okay.
So a pretty good cohort.
Okay. So I do want to go through a couple of brief definitions. We know that lots of people who are joining know what the conditions are, but there are some people who don't. The most prevalent of them is eosinophilic esophagitis. So Dr. Davis, can you tell us exactly what that is?
Eosinophilic esophagitis is a chronic disease that results from the accumulation of allergy cells called eosinophils in the esophagus that causes clinical symptoms like vomiting, heartburn, abdominal pain, nausea, um, difficulty swallowing, and sometimes food getting stuck in the esophagus.
Mhm.
So it, it in order for eosinophilic esophagitis, which is also called E.O.E because it's a very long name, instead of eosinophilic esophagitis, we recommend just saying E.O.E. In order to diagnose it, one needs to have the symptoms associated with it and also have evidence of that eosinophilic or the allergy cell inflammation in the esophagus.
Okay. And we know that there's some other less common eosinophilic diseases. Dr. Olive, can you touch on some of those?
So in terms of the gastrointestinal tract, eosinophils can be found really throughout the gastrointestinal tract. As Dr. Davis just mentioned, E.O.E. is the most common, what we know the most about, what has been studied the most, but we are starting to, through the Seeger Consortium, starting to study eosinophilic GI disease in the rest of the GI tract, and hoping to get better understanding of the symptoms, the natural history of it, and hopefully develop some treatments down the road. But essentially, anywhere in the GI tract can be impacted by eosinophils, and the symptoms can be variable depending on where they're found. So in the stomach, for example, pain and maybe vomiting might be more prevalent, whereas in the lower GI tract, maybe more symptoms of pain and diarrhea, maybe rectal bleeding and so on, and failure to thrive as well. So,
all right. So Dr. Davis mentioned you guys kind of bumping into each other in the hallway and discussing patients and kind of deciding to do this multidisciplinary clinic moving forward. Tell us a little bit about then. We know that the diagnosis of E.O.E. is relatively new, so to speak. Most people say about maybe 25 to 30 years that people have been talking about eosinophilic disorders. What's the difference between then and now?
is that for me or?
Either of you.
Yes. Well, I think things have really evolved in a number of ways. Then and now, I think early on people weren't sure what was driving it. Was it just another sort of manifestation or something on the continuum of reflux, or was there some other reason for it? And it turns out that allergy, particularly food allergy, became widely known as the reason for it early on. And then treatments, of course, have evolved over time, with the initial thought of, elemental diets were very common early on to try to really get the condition under control. But, we subsequently found out that quality of life issues are really prevalent with food avoidances, and particularly with an elemental diet. People want to eat food, kids want to eat food, right? So there's been an evolution of how we approach it in terms of the treatments. And I think, but really, in my mind, the evolution we've seen over the last 15 years or so probably pales in comparison to what we'll see in the next 5 to 10 years, just because there's been so much knowledge gained by many different groups, including the group in Cincinnati with Dr. Rothenberg, in terms of the mechanisms, what happens at the tissue level. And so there's a lot of therapy targets that are available now, or that potentially available for study. And so we'll see some more drugs and more options coming down the road for our patients.
Okay. And on the allergy side, Dr. Davis?
Yes, I think in the beginning, like Tony said, we didn't really know exactly what was causing it. So we would have to do trial and error just from the foods that were causing the symptoms. And we didn't really understand if there had to be a positive test for that food to, to contribute. I think advances came with the discovery that if you eliminated the major food allergens, there was like, 80% effectiveness, right? So that was a huge advance that came out from Amir Kagwala's group in Chicago. And then the other advance came when we realized that there was some connection between a positive test, potentially, and the reactivity or the ability of a food to cause inflammation. We're still working that out, but what it allowed us to do is to expand the diet. As Tony mentioned early on, we're just like, okay, the only option is to take all the food out, right? Or treat with medicine. And so later on, we began to be able to say, okay, no, we don't have to take everything out. Let's work on the major foods and see which ones are most causative. And so now we know much more about which foods are most likely to cause the inflammation. So that's been a huge advance. And I agree with Tony that these targets, understanding the mechanism that causes the inflammation, has allowed us to utilize very precise drugs that we call biologics in order to block specific pathways in order to decrease the inflammation. So that has really been, I think, very exciting over the past few years.
So we're going to talk a little bit more about that line of drugs when we start asking questions, because everybody wants to know more about those and how they work and what the future looks like for those children who are on them. But before we go there, you spoke a little bit about my next question in terms of advancements. So let's talk a little bit more about current trends. I know I've spoken to moms who say, I don't count scopes. We count scopes. AJ is going to be 15 in July and he's had 44 scopes. And when he was diagnosed when he was 1 year old. That was the trend then. You tried food and every quarter you scoped and you scoped and you scoped to figure out what was going on. So I know that we've spoken before about moving away from that. Dr. Olive, can you talk a little bit about how we are using other markers and signs and symptoms to determine reactivity versus doing a scope?
Yeah, so, the traditional thought has been that symptoms don't really necessarily correlate with endoscopic findings, which is why we've always wanted to do endoscopies to verify that, particularly in the setting where you're reintroducing major foods between each major food reintroduction, we've always wanted to have some documentation that the inflammation was under control beyond just a patient telling you I feel fine.
Mm-hmm.
Right. And I think for the most part, that's still the case, although, that it may or may not be, but at least in 2021, that still seems to be the prevalent thought. I think down the road, we may get better about, maybe waiting a little bit longer for symptoms to develop or realizing that if you do wait longer than the 3 months, eventually symptoms will show up if the E.O.E is active. We just haven't ever really looked at that.
Okay.
And so that's something that may change down the road. But patients are always are sort of in a hurry, not in a hurry, but anxious to introduce that next food. And the rate limiting step to doing that is to do a scope. And so the willingness to really wait longer isn't always there. But I agree with you. I think there is concern over the number of scopes that we do. A lot of people are concerned about that, particularly in younger individuals. There's anesthesia literature that suggests that particularly children under 3 years of age really may have there may be some neurodevelopmental implications to doing multiple anesthesia events, and so we're very cognizant of that. And so along those lines, a lot of people are working on non-invasive ways to determine whether activity is EOE activity is there or not. The group in Denver has done, looked at transnasal endoscopy, which is tolerated in older individuals more than it is in younger individuals. It does not require anesthesia. And looking, the downside to that is you're only looking at the esophagus, but in many cases, that's all you want to see is the esophagus with just follow-up studies. People are looking at salivary markers, blood, tissue markers, et cetera, that Dr. Davis may be able to expand on. But the bottom line is that there is concern over many endoscopies, and that is something that the E.O.E research community is very in tune to in terms of trying to find non-invasive, less invasive markers.
So Dr. Davis, what would be your recommendations in terms of spacing out the scopes? What other things should we look at so we can make decisions on how often to scope?
Well, I think, of course, Tony is the scope expert, but I will say that I agree with many of the experts that say if you ask 100 gastroenterologists, how long they wait, right, you'll get 100 answers potentially. I do think that that we, at Texas Children's in our clinic, we know about what happens in most patients, but what we try to do is really look at the individual patient that's in front of us and give that personalized approach, because not one plan fits everyone. Mm-hmm. And so I do think we have been very judicious in our approach to our patients in making sure that, when a scope is done, and I'm only saying this because I've been in many, many rooms with Dr. Olive, is that, when a scope is done, we have a really good reason to do it, and we have a plan as to what we're going to do, and we tend to really, again, be as cautious as we can with the patients in terms of doing the scopes. I think we've learned a lot about natural history too over the years, because initially, right, we didn't know what kind of damage would be done if the inflammation continued for a long period of time. We know now that there are actually different types of patients, and some patients will go on to develop this restrictive disease, with inflammation faster than others. So we kind of try to get a sense for that patient, what's going to be most helpful, and so that's my non-committal answer. I think Dr. Olive probably has more kind of guidelines, but I would say that I've been, as we work with patients, I think the individualized approach is a good one. Tony, did you want
here's
to?
an easy one for you, Dr. Davis. Talk a little bit about the role of patch testing, serum allergy testing, and how those things relate to EOE.
Yeah, so we know that in EOE, there is an immune response that's happening to food. Unfortunately, at this time, a lot of studies have been done on the blood testing, the skin prick testing, which both test for immediate type reactions to food. And a lot of studies have been done from one center on patch testing, and that looks at delayed response to food. What we know is that in general, patients with EOE have higher positivity rates of these tests. Mm-hmm. But what we know is that it doesn't always correlate with what works when you take a food out of the diet or not. We know in general that there's this immune reactivity to food, but it's difficult for us to pinpoint with those tests. which food is really causative, so or causing the symptoms. So it really, we've moved from trying to use those tests in a very precise way to getting a global sense of what's happening with the foods, whether they're causing symptoms, plus is it positive, plus do we know that this is a food that's likely to cause inflammation. And as mentioned before, the scope and symptoms are what we follow.
And then just to add a layer to that, what about environmental allergies?
So environmental allergies, we know, do also have a role. We need more studies, I think, to really understand how large of a role it has in some patients that are allergic to seasonal allergens like tree pollen, weed pollen, or grass pollen. During that season, we know that eosinophils can increase in the esophagus and in the blood. And so we do strategically plan to assess eosinophilic esophagitis and its response to food avoidance in times that are hopefully out of the season. That's a tough season for the patient.
Okay. And Dr. Olive, in terms of diagnostic criteria, we know ultimately we're still using scopes to figure out what's going on. But I know when AJ was diagnosed, he had to be on a PPI for a period of time before they would even consider scoping him. Has that diagnostic criteria changed? And if so, how?
It has. Again, the prevailing thought previously was that in order to sort of distinguish between eosinophilic esophageal eosinophils that were related to acid reflux and E.O.E, one needed a trial of a proton pump inhibitor. And for a period of time, there was a entity termed PPI responsive EE or E.O.E. Well, it looks like that entity is simply just a continuum of E.O.E. So it's part of E.O.E. There's just a subset of patients that tend to respond better to PPIs. It would be the same as calling somebody budesonide or steroid responsive E.O.E. and subcategorizing that as still E.O.E. It's all part of it. It's been shown by Rothenberg and others that at the tissue level, molecular level, that the signature patterns are very similar between those two entities. So it's essentially part of E.O.E. And so we do not use that as a diagnostic criteria on a day-to-day clinical practice from a clinical practice standpoint. Many research studies are still designed with that criteria in mind, and I think that probably needs to change because I think a lot of research studies are excluding PPI responsive patients that have eosinophilic esophagitis, and so I've advocated for that to change, but it's a slow process.
So you mentioned exclusionary criteria as it relates to research. Let's talk a little bit about that because Texas Children's Hospital is a research center now. We are part of the consortium, and there are very strict guidelines. I learned that there are very strict guidelines to who is admitted into research studies and who is not. Can you talk a little bit about how they come up with that criteria and why?
Yeah, I can comment on that. So whenever a study is looking at a specific treatment modality, really the study needs to have patients in the trial that would respond to the treatment compared to placebo. So you don't want to enroll in a study patients that might only have a little bit of response or might get better on their own, and typically in this situation, it's patients that just have a little bit, mild disease, that you might not be able to detect a difference. And so for most of the studies, they want to enroll patients who have, really significant symptoms that they would be able to tell if the treatment was working, because in order for a drug to get approved, you have to show kind of a minimum difference between the patients that aren't getting the medication and the patients that are getting the medication. And so in order to maximize that difference, typically patients, a specific kind of patient that really is not getting better on a certain treatment, like proton pump inhibitor, would fit that bill. So, and the other thing that the studies don't want is they don't want for a patient to be enrolled in the trial and then have a lot of changes within the trial that are not related to the treatment being given, right? Because you can imagine that if a patient enrolled in the trial and then in the middle of the trial remove certain foods, right, you might attribute the improvement to the drug rather than actually what happened. So that's I think the reasoning behind the strict criteria, inclusion and exclusion criteria is what we call it, who can be included and who should not come into the trial.
Okay. So before we move on and start taking questions, because we have questions of like, there's a huge spectrum of questions that people are submitting. So before we start talking about the questions, I want to talk a little bit of how we met. So I moved to Texas in 2014, and my son AJ was already diagnosed, and he had his first visit with Dr. Olive in December of 2014. And soon thereafter, he met Dr. Davis. And I think it was probably, I don't know, I guess 5 years ago now. So a year later, when I started AJ's Fight. So I'm going to ask each of you, you're both board members and have been working with me diligently, even when I'm having tantrums. And so I just wanted to know, like, why AJ's Fight? Why are you guys committed to the cause? I'll start with Dr. Davis.
Well, as everybody on the Facebook Live can tell, you are very passionate about this disease. At the time you started AJ's Fight, I did feel like patients needed some other patients and families needed families to connect with. And I'm a huge proponent of getting families together for support. And you really wanted to support, you also wanted to further the research. And so I also was really grateful for your having that vision that actually we could not only bring families together, support them, but then also help us to advance the knowledge of how to treat E.O.E and other EGIDs. So that's why I do it.
And Dr. Olive?
Yeah, I would agree with that. Well, you know, we support AJ's Fight first and foremost because we really like you and AJ. That's one reason. But beyond that, it serves just such a tremendous need for the community. I think it provides, like Carla said, tremendous resources and support for those out there with you know, families that are dealing with these eosinophilic conditions. And anything that can really sort of highlight and raise awareness in our book is worth supporting, and that's why we're supportive of it.
Well, thank you for sharing that. And so we're going to actually move on to questions, and I have a whole sheet of questions. So you guys ready? So a lot of families complain about leg pain. And for a long time, I was one of those parents who kept saying, AJ's continuously complaining about joints. Do you guys have any insight on where that comes from and how we can treat it?
That's a good question. That's a really good question. I can take a stab. Tony, you want me to take a stab at it?
Yeah, I mean, well, the bottom line is that we do see some patients with these complaints from time to time, and it's, not, I mean, there is an association, but it's not clear cut what that is, whether it's part of a myopathy that's associated with it, or some rheumatologic, other autoimmune condition. It can be a multitude of things. And, I think people are always interested in these subsets of EOE, like EOE with mitochondrial disease, EOE with dysautonomia, things of that sort. And there's all these, with Ehlers-Danlos, there's all these associations. And I think we've had a few patients, Carla and I have had a few patients that had those complaints, but I don't know that we've been able to pinpoint exactly what that was. Would you agree with that, Carla?
Yeah, I think so. I think we need a lot more research into the subsets and what's causing all of these extra gastrointestinal symptoms, what we would call them, because we definitely see leg pains, and so I do think that there's a reason. We just don't exactly know what it is right now. So we need more research in that area.
So I know for me, I talk to a lot of parents whose children do have some of those other comorbidities. They have, Ehlers-Danlos, they mast cell. But from a clinical perspective, how pronounced is that? Like, do you see lots of kids who have other things going on, other rare conditions going on, or is that just kind of isolated?
From my standpoint, I would say the majority of the kids that we see don't have those extra, like dysautonomia. I would say the things that are less common, the dysautonomia, I see more so the connective tissue association. I would say for the mast cells, I think I see those patients more, right, than the patients that don't have they come back to me more frequently. But the vast majority of our patients don't have those extra gastrointestinal manifestations. That's my gestalt. It is a subset of patients that really have those symptoms.
Dr. Olivia, I know that Dr. Chu handles a lot of the motility stuff, but just here in the last maybe 18 months, we come to find out that AJ in particular has other things that are happening that are not necessarily related to the EOE. And we did some testing and found out that, his esophagus is not working right. And he's always had gastroparesis that has just gotten worse for him. Are you seeing a lot of kiddos who are coming in where we're associating everything to EOE, but then later finding out that maybe these are separate and apart issues?
Well, I wouldn't say we're seeing a lot, but I think there are patients that have other conditions that may or may not be related to the EOE, and I think we're still trying to sort that out. We certainly see plenty of patients in GI that have motility issues that don't have EOE also. So, you always like to sort of unify the diagnosis in one particular patient, but it is possible to have two different conditions going on, two different sets of the genome that may be affected, or maybe genes that are very close together that are impacted, that manifest as in a certain way. So, I think to answer your question, we don't see a lot of it, but we do see some of it. And in EOE, some of the things that could cause, certainly the esophageal motility issues could still be part of his EOE, even if his EOE is under good control, he could still have some underlying tissue fibrosis that's causing the motility issues. The gastroparesis could be either unrelated or related to, and I'm not talking about AJ specifically, just in general, EOE patient could be related to eosinophils in that part of the GI tract. It could be related to connective tissue disorder like the Ehlers-Danlos, or maybe even the dysautonomia. Those can present with gastroparesis issues as well. So there's so I think there are some patients who have a wide or are very complex, but most patients with EOE are relatively straightforward in our experience.
Mhm. And the one thing that I would add to Tony's description, which was great, is that we really try to address all of the symptoms, because we know that even if we decrease the inflammation in the esophagus and improve the gastrointestinal symptoms, the other symptoms don't automatically get better.
Yeah.
And so we pull in the specialists that are needed for us to really get to the bottom of all of the symptoms. And I'll say that for patients that have mast cell disorder or disease symptoms, I treat them kind of like they don't necessarily have EOE, right? I treat them like the patients that I have that have mast cell activation symptoms of flushing and hives and things like that. So I think the approach really just has to be broad and really pinpoint all of the symptoms.
I think that we're seeing that there is a specific cluster of subsets. Do you guys have any idea why?
I would say that it has to do probably with it's multifactorial. One, definitely genetics probably play a role, and we're learning more about that. Need to learn even more, but then also environmental in terms of exposure in the environment, not only to diet, but we know the microbiome is impacting inflammation in the body, and so I think there are really a multitude of things, genetic and environmental, that are contributing. And so, again, we still are learning more about it, but that's, I believe, why these clusters are, why they exist.
Okay. And I think Nicole has a question for us.
Yes, we're getting some questions on Facebook. Do you guys see any health disparities in when diagnosing persons of color? Sometimes we see and notice and hear stories of patients of color that are experiencing longer times of diagnosis, longer times of not being symptoms and not being believed. We already know that there are health disparities with persons of color. So just wanting to know how you combat those health disparities in diagnosing persons of color.
Yeah, no, I think that exists throughout medicine. I think that's has become quite evident. There was interesting, I just read an abstract today about EOE diagnosis in different ethnicities, and African American populations have a significantly delayed diagnosis of EOE compared to their Caucasian counterparts, was the gist of that. So yeah, I think that's an issue that society in general is starting to recognize more, and that it exists, and hopefully we'll be addressing it in a more efficient and appropriate manner in the future.
Yeah, I think I agree with Tony that it definitely exists, and it's interesting now. This pandemic has really brought out that health disparities exist more, and so the Consortium for Eosinophilic Gastrointestinal Researchers has formed a diversity committee, and that diversity committee is getting together, all of the literature on disparities, and really coming up with strategies to identify patients that haven't been diagnosed, that are probably out there. They're also identifying, I'm in the diversity committee, we're also identifying how we can make research more accessible to minority patients and easier to participate. So I think it's an exciting time in the field to really delve deeply. The Consortium of Eosinophil Gastrointestinal Researchers has actually found that when you look at Medicaid coverage over the United States, really the more the areas that have Medicaid coverage, it seems like there's disparity in E.O.E diagnoses, right? So I think we're going to learn in the next few years way more about who has E.O.E and try to expand access and expand the information so that these disparities can be minimized. I think you're on mute. I think you're on mute.
I think that's like the phrase of 2020, 2021. You're on mute. Anyway, I've said that more in this last year than anything else. I'm an educator, so we understand that you are pediatricians, but there is a lot of talk about adult doctors and where do adults go for care. So a lot of times, where do you point adults to in the area? Where's the adult version of you guys that adults could go to for care, because they need the adult version of you guys just as much?
Yeah, I think it varies from region to region and city to city, but it is a big problem, the whole transition of care, not just in E.O.E, but in many facets of pediatrics, because the programs that we have in pediatrics, particularly in academic settings where we are really phenomenal, and you often don't find those in the adult care setting. It's more fragmented. And so, at least locally here in Houston, we've had difficulty finding a similar program to ours for our patients that are transitioning. We've had at times doctors that were willing to sort of take the patients, but the feedback that we've gotten is just it's not the same experience. And I think that's just sort of true across the board in all pediatric conditions for the most part, not all, but many. So it's a real issue, and one that I think should be tackled more vigorously than it has, I guess.
Yeah, and I think that my approach, we're trying to train so I'm trying to train adult allergists that know EGID. And we do, Tony and I in our clinic have trainees that come through, and we teach them about EGIDs so that they can go out and in their practice be a resource. And so we're constantly working not only to train our trainees, but also train our colleagues to see these patients and encourage them to connect. And we do have some EGID specialists, and I think, as mentioned, the adult experience is just different than if you think about your pediatrician and then you think about your adult doctors. They're just very different. But we definitely, in Houston, we do now have gastroenterologists who we can transition to.
I smell
I should also mention allergists, immunologists. We can see children and adults. So I don't really ever have to let my patients go.
I smell a bridge program happening, like, this whole multidisciplinary pediatric and adult program all in the same building. I see it coming. We're going to talk about that.
With AJ's fight, yeah.
So let's see. So we had another question about recommendations for kiddos who have controlled EOE, but continue to experience cough, sleep disturbances, and belly distension. So we know that there are times where kiddos are having other difficulties, you know, whatever, but the EOE is controlled. Do you have recommendations in terms of where a parent could go if they're still experiencing these other things?
Yeah, well, I think continued evaluation by the gastroenterologist for other conditions like we spoke about earlier. Are these independent conditions not related to the EOE? Or are they somehow related? You know, so like bloating and so on could, I mean, that's a relatively non-specific symptom that could be due to lower GI tract eosinophilia, but could be due to lactose intolerance or constipation or functional dyspepsia. There's a variety of things, and so it would require a more detailed examination and evaluation by the gastroenterologist. Likewise, cough would probably fall in the realm of both of our practices. It could be related to acid reflux, but it could also be related to sinus or allergy or some other, you know, pulmonary disorder. So it would just require a more extensive evaluation.
Let's see. So we talked a little bit about transition. I do want to talk a little bit about quality of life. It's a conversation that took me a long time to get to. The idea of what life would be like if I, as a parent, let go a little bit. You know, I'm probably the ultimate, like I wear the badge of helicopter mom, and it's like, no, we're going to do this, we're going to do this, we're going to do this. And over the years, you guys have worked on me. And so just the ideas of quality of life and what that looks like, especially for our kiddos who are getting older and transitioning. What are you guys' idea on where parents can kind of let up a little?
Well, you know, we're both parents, and it's not easy to let up. You know, it really isn't. But I think, you know, sometimes it does take somebody from the outside sort of counseling you and encouraging you to do that. And when the right time to let up, I don't think there's one answer to that. I think it just depends on your child, on you, on y'all's relationship. And you know, it's hard for parents, even when you have healthy kids, it's hard to sort of let up on them. But when they're going through something like EOE or some other chronic condition, it's even more difficult. But I think it's just the understanding and the recognition that the sooner you let them be more independent and take ownership of what they have, the more you know, the more they're going to be able to handle it psychologically, I think, and you know, the more prepared they will be for life ahead. You know, I think.
Yeah.
Anything to add, Carla?
Yeah, I think I agree with Tony, and it's really important to know your child and to know yourself and your relationship. I do think there's a place for bringing the child in to the decisions about treatment, because it's easy when children with we are infants or toddlers, right? We're controlling everything. And when they're school age, we think we're controlling things, but they may be controlling more than we think. And then when they get to be junior high and high school, I think late junior high, definitely high school is the time to begin to really engage and really listen to how the disease is affecting them and how how they feel about the different treatments. We have so many options now that used to be we had one option, is just what you have to do. Now we have several options as to how we can treat your child. And I think choosing the ones that cause the best quality of life and control the disease, that's a win-win situation. And so it's not only what the parent thinks, but also it's just a combination.
Yeah, and EOE treatment's a perfect example of that. If you ask teenagers what they prefer medication because they want to be able to eat food. If you ask parents, they prefer diet elimination because they're worried about medication side effects, and so, ultimately, I mean, there's this discordance. And I think if we take the approach that it's going to be my way or the highway, then you're going to end up with an unhappy child.
And I think that a lot of us parents have to manage that mental health aspect of it. I know I have with AJ. Do you guys have any recommendations in terms of consistent therapy or just being in an environment where you can plug in a psychologist or a counselor for your child?
Yeah, I think that being really open to seeing a psychologist is very helpful. I just read an abstract that E.O.E patients or EGID patients that have food restrictions in many cases feel isolated or lonely. And food is so associated with our social events that we really do need to be open to that. Talking with a psychologist for the health of the family and the child.
So you touched a little bit earlier when you were talking about the biologics. And so I want to go into that conversation some. I know about two of them because AJ was on two of them, but I think that there are more than that out there right now. How is that changing how we're treating EOE? And what does the future of that look like? I know AJ's currently on dupilumab, and the idea that it's working, it seems to be opening up his diet. But does that mean that he has to be on it for the rest of his life until we find a cure? Or do we expect that something might shift with the treatment? I said a lot there. So start wherever you want.
Tony, you want me to start?
Yes, please.
That's fine. Yeah.
Okay, so there are several, I would say there are biologics on the market. Right now, there are three pathways that these biologic medications target. And one pathway is knocking out the production of the eosinophils. And then another pathway, actually the two other pathways are dampening the allergic response. Both of these contribute to eosinophilic esophagitis. And so right now, we know that they're effective. We have observed that if you stop them, the disease is still chronic. So they're not cures, they're actually treatments. And they can improve quality of life, but they're shots. There are no pills, and there are no other ways to take them. So they can be taken at home for adults and adolescents. The coronavirus pandemic has improved access at home. Not all of them can be taken at home, but a lot of them now because of the pandemic. But I think they have changed our ability to target immune pathways that affect a lot of allergic diseases and a lot of diseases that are targeted by eosinophils. So still, there are many more in development. There are probably 5 or 6 now in development. Well, I think the future is bright for learning more about them. That's what I would say about the biologics. Tony, did you?
Yeah, I would agree. I think it's very similar to what we have seen in inflammatory bowel disease, Crohn's disease, where the biologics have really been a transformation in terms of treatment options, treatment outcomes, reduced hospitalization rates, just all across the board have really been a transformation in the care of inflammatory bowel disease. And I think you're going to see the same thing in eosinophilic esophagitis. More options, better outcomes. And some of that better outcomes is that you are targeting specific parts of the inflammation, but a lot of it is that the compliance is better. It's easier to, I mean, while it's not easy to get a shot, it's easier to remember to get a shot once a month as opposed to remember to take your medicine twice a day or to avoid this food all the time. You know? And so I think that's a big aspect of it. And so I agree. I think the future is bright, and I think you'll see more and more of these down the road. And, you know, obviously the hope is a cure one day, but if that's not possible currently, I think this is certainly a very nice alternative.
Nicole, you had another question?
No, I thought I did. I was just I was just amening over here on all the stuff that you were saying. I was, when you were talking about mental health, I think probably the no offense to my child's GI and allergist, but the best thing that we did was add the psychologist and psychiatrist to my child's treatment team, and adding getting myself in therapy. So I will, you know, I'm doing a talk next week, so I will readily tell anyone that needs to hear it. That was what we needed to do for myself and my family. So I think it's not nearly talked about as much, especially as everyone says the food is everywhere in our society, and the loss of food and the grief that these kids experience when they are not able to just be kids. And the grief just over this past year and the loss of a lot of different things. So yeah, that was just me amening on every little thing y'all were saying.
So we've bounced around some, but I do want to go back for a moment because I did have a question here about the different stages of symptoms. We know that in infancy and toddlers is different than school agers and then the older kiddos. Can you guys talk a little bit about what you see in different age groups?
Yeah, so I think that's one of the things about pediatrics is that the developmental nature of the child lends itself towards sort of different manifestations of the same symptoms, or different presentations of the same symptoms. And so what we see with E.O.E in particular, as I think people, as you've alluded to when AJ first presented, is you know, sort of some feeding problems, feeding issues, feeding refusal early on in the infancy and toddlerhood. And then the older kind of young school age child may have more sort of non-specific symptoms of abdominal pain, maybe some vomiting. And it's not really until you get to the preteen or teenage years where you start, you know, getting that specific description of dysphagia, of food getting stuck or going down slowly, and sometimes even presenting in the ER as their first presentation of eosinophilic esophagitis with a food impaction. So, and we have had those patients as well where they've sort of had these symptoms and just thought it was part of life. And then one day it didn't keep going down, it just got stuck. You know, and that's more the adult-like presentation often where they're describing the symptoms to you. So there is a spectrum that we deal with, and it sort of really it sort of dictates the age of the patient, sort of dictates the questions we ask when we're suspicious of this diagnosis.
And from an allergy perspective, Dr. Davis?
Yeah, I would say that there are clear subsets of patients that really don't have the kinds of classic allergy symptoms like wheezing, hives, swelling, or any symptoms when they take any of these acute symptoms when they take the food. And so there's some non-allergic, and then there are others that have a lot of food allergies. And I've learned to begin to ask questions about eosinophilic esophagitis just because they're so linked. 80% of patients with eosinophilic esophagitis have food allergies. So the classic kind. So I do think that there are these two subsets. In little children, we actually, in many cases, can diagnose the food allergy first. And just because infants less than 2 are just harder to, and Dr. Olive has told me that they're harder to do the endoscopy, a little bit more risky. We end up really not diagnosing those patients until they're a little bit older in infancy, close to toddlerhood. But the allergies, again, it tends to be that there are these subsets, and the allergy can develop to environment at about 3 years of age. And that's when we can begin to test. The food allergies we can test at 6 months or even younger. But we do see that patients that have an allergic genetic predisposition tend to have that as very predominant symptoms into adulthood.
Okay. So I want to move into the conversation around navigating care. Lots of parents, I know when I first started this journey as a parent, I didn't know what E.O.E was. The first thing AJ's gastroenterologist gave him was Pediasure. That didn't help. And so, we had a diagnosis, but I didn't know what it was. I didn't know how to treat it. And 15 years ago, most people didn't know how to treat it. And we've gotten a lot of questions about how parents should prepare for these visits. How should parents prepare? Who should they bring with them? Do they bring older siblings that don't have E.O.E? Is it beneficial to have parents alternate appointments so that they're getting all of the information? How can they question their doctors or push for something that the doctors are saying, no, they don't want to do? What is your advice to parents as you guys deal with different personalities and how they're navigating the system?
Well, I'll try to answer that. I think, you bring who you want to bring. In this day and age, you may not be able to bring everybody you want to bring, but the most important thing is to bring someone who is going to be able to listen and absorb the information, because there's going to be a lot of information, right? And so, I think generally speaking, if you have several people in the room, it's probably different. Some will get parts of the conversation, some won't get parts of the conversation. Is that what you're asking? I think that might be what.
Well, not necessarily having a whole lot of people in the room, but I think that there are a lot of parents, especially with delayed diagnosis, who feel like they were complaining about the same things over and over and over again.
I see.
They were saying, my kid is going through this is what's happening, and it's still diagnosis deferred. They don't get the treatment that they're looking for.
Right.
And because it is a lot of information, what ideas do you have for them to be best prepared for these appointments?
Mm-hmm. Yeah, I can weigh in. I think it's really important before you get to the appointment to write down your questions. When you're in the appointment, it can be overwhelming, all this information coming at you, and you may forget the things that you thought about at home. So writing those down, I think, is important, and referring to them during the visit is important. I really encourage everyone who's involved in the treatment of that child, which is the whole family, and specifically the authority figures who may be feeding the child or are involved in going to the grocery store and how the food is stored at home. in many cases, not everybody in the home understands the importance of food avoidance. So I encourage those people to come. And I do think that it's tough if you're a provider, if you feel like there's something more that needs to be done and your provider says that there's not more that needs to be done. I think that one of the strategies that have worked on me as a provider is if a patient tells me, oh, I read that this could be associated with this, and my child has symptoms that are consistent with this and consistent with that. Do you think we need to see somebody? I think that's an effective way. You're an informed parent and you've noticed that your child has symptoms that go along with this thing that you've read about. What does your doctor think about just getting some opinion about it, right? Even if it's just an opinion, right? I think that can be very effective for compassionate providers. I would say that if your provider is really stonewalling you, to look at the options of getting a second opinion.
And I think that brings up an interesting point, because I have always felt that you guys have been receptive. Anytime I come and say, can we look at this? Can we look at that? You guys hear me. But I've also been in situations where I felt unheard on behalf of AJ. And there are not a lot of options. Here in Texas, here in Houston, I don't really know of another team. And I know that we have these large places that you can go where research is happening and that kind of thing. But most of the parents that I speak to kind of feel locked in. So what would they do in that type of situation?
Yeah, you're right. There's not, particularly very specialized pediatric conditions such as E.O.E tend to be centered around areas of centers of excellence or centers of expertise, and those are few and far between. And it's tough, when parents' intuition is very strong, and if you feel like somebody is not paying attention to that, then I would highly encourage you to get a second opinion. I think one of the things maybe the pandemic has sort of brought up to the forefront is the telemedicine, and so I think that is an option now. You don't necessarily have to travel to Denver or Cincinnati or Philadelphia or wherever you wanted to go to. You can have a very effective conversation and visit via telemedicine now. So that's something I think people should keep in mind if they feel lost.
Okay. Anything to add, Dr. Davis?
I agree with Tony that now there are more options to reach out, and at Texas Children's there's a online scheduler. I don't think you can get into the multidisciplinary Egypt clinic that way. But there are options for you to reach out, and I do know that that just like this forum is available, there are forums and physicians, including ourselves around the country, who would take questions from folks, who's the best person in my area, that kind of thing. So you may not be aware of somebody who is a specialist that's close to you. So the other thing I would say is looking on the see your network, the website, in order to find close providers is one way that you can also find people.
I think Nicole has another question for us.
So we know that we have a subset of patients who have those IgE mediated allergies, and So for a lot of those patients, they may have had to do in-office food challenges. What are your thoughts about having to do some of those in-office food challenges for some of those kiddos who may have had some of those IgE food allergies?
I think that the oral food challenge in office is a very, it's actually the gold standard to diagnose classic food allergy. And so, yes, if you have those antibodies, I think it is very helpful to have those challenges to know, um, should I avoid this because I might have a life-threatening reaction? Because if you have a reaction that's immediate to, and by immediate, I mean within a couple of hours of eating a food, and you have those positive food-specific IgE antibodies, then you could be at risk of having a much more severe life-threatening reaction. And so it's helpful to have a food challenge to understand whether you are at risk. So if the food challenge is positive and you have symptoms and are treated, then you do have that risk. If the food challenge is negative, then you don't have that risk. And unfortunately, right now, this is the only way we can tell. So I do think it is a good idea to engage in oral food challenges in order to sort this out, because it's very important, I believe, for a person to really know what they're allergic to and what they're not allergic to from this life-threatening standpoint. You really need to know, do you need an EpiPen for this? Should I be worried if I eat something with this food? So I do endorse that.
And I'll just tell you that Dr. Davis is food challenge queen.
I like getting to the bottom of no ambiguities.
So before we close out, I just want to talk a little bit about what's in the pipeline. Like, what are you guys looking at right now? What new advances can we expect to start hearing about?
Well, I can talk about the fact that these new biologics that are coming out are targeting not only the eosinophil, but eosinophils and mast cells, which cause this, immediate reaction. So I'm looking forward to this new biologic coming out that would just knock out both of those, because that would make my life like a lot easier and simpler. I think also there are people with ages that they're E.O.E patients, but then there are patients that have E.O.E and eosinophilic gastritis, gastroenteritis. It's affecting their stomach, small intestine, colon. And for many, many years, we just didn't know much about the lower gastrointestinal tract. So coming out, we're going to start learning and getting more information about those so that we can really treat everyone that has EGIDs. So I think that is a really nice thing that's coming down the pike.
Okay. And Dr. Olive?
Yeah, I think that's right. I think the new therapies are exciting. The biologics, obviously. I think soon we'll have a commercial oral viscous budesonide. You won't have to mix it with the Splenda anymore, or with honey or whatever you're mixing it with. So that will be good. I think it was alluded to earlier, we're going to start having subsets, what we call phenotypic subsets of E.O.E, and we'll be able to identify which patients. I think it's going to be a lot like Crohn's, where certain patients are more at risk for getting fibrosis and others aren't. And I think if we can identify which ones are and which ones aren't, and perhaps even which ones have no risk, then that will sort of decide how aggressive we are with both treatments and with surveillance, endoscopies and things like that. I think we'll see less invasive markers of inflammation down the road. So I think there's a lot to be optimistic about and to look forward to in the future. And there's a lot of people working on this condition, and that's always a good thing.
Nicole, do you have any closing comments?
No, just excited. Sometimes it's hard to be hopeful. My kid is on a biologic and she's gained 5 foods. We're going for our first scope. We have been trialing uh, corn for, I don't know, a year now, a year and 20 days. It seems like we started corn February 2020. So we are just hopeful for the future. So I'm just thankful for all that you guys are doing for the cause. So thank you.
Yeah, and I'll echo Nicole there. We could probably talk for the next 3 hours on a whole lot of different things related to this. But I'm happy for the conversation. Thank you for having the conversation with us. Thank you for being part of the team and taking such good care of my son. Um, I'm sure that people will continue to drop questions in the chat as they view this. So I may have some follow-up questions that we'll talk about offline. And I hope to be able to do this, moving forward, maybe once every 3 months or even once every, once a month eventually. I think that it's a good forum for us to have conversations about what's coming up and just continue to provide information to the community that doesn't really know what's going on. So again, I'm eternally grateful to you guys. I know you guys are busy. And just thank you for joining us. Do you guys have any last comments?
I would just say that we're happy to participate, and we really are thankful for your organization in terms of what you're able to do to get the word out about E.O.E. and eosinophilic gastrointestinal disorders, and provide people with families with these conditions the resources that they need to move forward.
Thank you. And Dr. Davis?
Yeah, I would just echo that really, really grateful for AJ's fight, and it's been really thrilling to partner with you and Tony to see the advancements in this field, and we look forward to being a resource for the patients.
Thank you. Tune in on the 30th of May when we're going to actually hear more from Nicole Webb and her daughter on her journey. And to be determined a date soon where we'll be talking with Dr. Chu, who is a specialist at Texas Children's Hospital in motility, and we'll have that conversation. So thank you again for joining us, and everybody have a good night.
Thank you.
Thank you. Bye.
Goodbye, everyone.